So I do appreciate that introduction, and Brent and I have known each other a number of years, and have had similar visions for the last 15 years, and I think have really come together within the CCI and other initiatives to meld our thoughts together to create something new. I've been practicing medicine as a pulmonary critical care doctor since 1987, and I've certainly seen a lot of changes in healthcare over that time period. But I have to say I've never seen as rapid a change as I've seen in the last 5 to 7 years. And what scares me about that is I think the next 5 to 7 years are going to be even more rapid change than has happened in the last 7 years. So we all just need to be prepared for that and engage that. What I've been asked to talk about is clinically integrated networks, and more specifically, what actually makes a clinically integrated network successful. And so I'm going to talk a little bit about the drivers that have driven the idea and the thought around creating clinically integrated networks. Then I'm going to talk about the structure of a clinically integrated network and all the components that are necessary to make a clinically integrated network successful, or to make it a good network. And then at the end, we'll talk of just a few minutes about why even good clinically integrated networks fail. Okay, so we'll get right into this. And this is a slide that everybody's seen 1,000 times. Okay, and this is part of the drive to think about population health, total health, clinically integrated networks. So the cost of healthcare in the United States is continuing to escalate. And it's continuing to escalate everywhere. We always think about other industrialized countries having less expensive health care, and I will tell you that that's not necessarily true. So I was in a summit in San Francisco not too long ago with all the leaders of the national health system at a Kaiser meeting. So it's a Kaiser Care Management Institute leadership meeting and the national health system. And luckily, because of some relationships there, I was the only other person in the room. But the national health system was there trying to figure out from Kaiser how to control their cost. They have escalating cost in the United Kingdom, and a lot of that depends on what you include in the cost. We in the United States tend to think of the cost of medical care as the medical spend. In other countries, they add on top of that the cost for social work and social services. And when you layer on a graph like this, the cost of social services, we actually even out when you start comparing us to the United Kingdom, France, Germany, and other places. But nonetheless, it's still an escalating cost, so much so that in the past, industries, companies, the health plans have been mostly managed by HR people. That is evolving now because it is such a big expense that it's reached the level of a CEO decision in terms of how they're going to manage their health spend. And some examples, just to put it in a context, I'm sure a lot of you this morning had a cup of Starbucks. I see a cup of Starbucks right there. Starbucks spends more money on health care than they spend on their coffee beans. General Motors spends more money on health care than they spend on the steel to create their cars. So it is a major expense, and they're beginning to view that like any other vendor. It used to be just something that was off to the side, and we're just going to pay whatever our health care costs, and this is our core business. Health care is becoming their core business, and we either have to act like a vendor and provide a better product for them, or they're going to figure out how to do it themselves. And what's been more frustrating for them is that in the face of all of that cost, we've not provided a good quality product. And so again, and this is a difference compared to other health systems across the country, when it gets down to basic care of patients, we don't provide a good standard of care. So as you look at the things where we know that there are standards that should be performed for certain diseases like diabetes, heart failure, et cetera, across the board, historically, we've only provided about 50% of those standards across the board for a population of patients. We're very good at high technology medicine. We're very good at cardiac interventions, at cardiac transplant surgery, at neurosurgery. People travel all over the world to the United States to get that kind of care. but they don't travel here to get health maintenance. And we were very bad at that. And so some of the reasons that we think some of that happens is that we're a very fragmented healthcare system. And for the most part, we function as independent hospitals with independent physician practices doing their own thing, all getting paid differently, all the incentives misaligned with each other, and nothing really oriented toward a true approach to population health. More and more, that's moving to an integrated delivery system, at least, so that the hospitals and doctors are functioning as a single unit. And contracts with employers and insurance companies are now going as a single payment to an integrated delivery system that then decides how the money is split between hospitals and physicians. And then one step beyond that is having a clinically integrated network, which may consist of an integrated delivery system plus other pieces to form a bigger puzzle that we'll talk about going forward. There's not a lot of just readily available data out there on larger clinically integrated networks, particularly from a commercial standpoint, and how well they're doing or not, because you can understand that some of those are confidential contracts, and a lot of times they're not willing to share that data. What we do have some data on is the Medicare Shared Savings Programs, the ACO type data, because that's more public data. And just to point out that that is growing. So this past cycle, there were 89 new MSSP programs, which brings the total up now to about 424 total MSSP programs across the country. And that serves about close to 8 million beneficiaries now. So that model is continuing to grow. And I'll tell you that there's many more clinically integrated networks out there that don't participate in MSSP. So this is just the tip of the iceberg of what's out there and what's happening. But we know it's growing. HHS and CMS has taken the tack that they're going to push alternative payment models. And this statement came out just in the last couple of months, I think, from CMS, that they're going to move from typical fee-for-service payment to alternative payment models. And you can see that by 2018, they plan to have at least 50% of all payments to physicians and to hospitals in some alternative payment model. So it's no longer just you create an interaction and you get a payment for creating that interaction. It's going to be attached to, and this is how they describe it. So it's going to be attached to either working through an accountable care organization as a Medicare Shared Savings Program, medical homes, bundled payments, comprehensive end-stage renal disease programs, et cetera. And then on the far right, presently, eligible pioneer accountable care organizations. And my prediction is that's going to continue to move more and more towards some types of global payment to a single entity that's responsible for the care, and you either meet the quality parameters and create some shared savings that you participate in, or you don't get paid. And so that is the movement. And this isn't just, I think I heard Sean Bryan mention yesterday that, we think a lot of this has been driven by the government. It really has not. This actually started by employers. Okay, and the government has copied that, and they certainly want that to happen too. But in my dealings with employers around the upstate and the rest of the state of South Carolina, and even outside the state, that's their main goal for the next few years is to get control of their health care spending. And they're pretty bright guys and pretty innovative, and so if we don't do it, right now they're looking to us to do it. They realize that the past model has not worked for them. And so they're looking at us, and they're looking at us with a vendor mentality that we need to get control over those costs, and if we don't, they're going to take it over. They're going to put their own clinics in, they're going to hire their own docs, they're looking for alternative ways to control those costs. And luckily, none of the things that they've tried either have worked very well, and so they're looking to us to help figure this out. And so not only is CMS doing that, but they've pulled together other groups of individuals, payers, insurers, that are working together to move this across the commercial market too. So if you think you're going to avoid this, you're not. So it's not just the government, it's going to be the way we all get paid. And so again, kind of recapping, I just want to make sure that we understand that we can continue not to pay attention to this, but the people out there who are actually paying the bills are very concerned about it, and they're going to make sure that this model continues to move forward in one manner or another. And so, again, since we don't have a lot of clean outcomes around commercial products for clinically integrated networks, I'm going to talk for just a minute about the Medicare Shared Savings Program and some of the outcomes related to that. If you had to pick a way to manage care in a population, my opinion, the Medicare Shared Savings Program is probably one of the worst ways to do it for a provider, okay? Because there is no real narrow network. I mean, it is a narrow network in one sense in that you have a defined set of providers, but patients can make the choice to move anywhere they want to go any hospital they want to, any doctor they want to. And you can make the case, well, if you're really providing good care and et cetera, et cetera, et cetera, you can convince the patients to stay within your network. And theoretically, that's all true. But sometimes you have to make tough decisions as a provider of care or as a payer of care to incentivize patients to do certain things. And in this model, you really don't have the ability to do that. But it is designed to decrease cost in the Medicare beneficiary population. And so how well has that worked? So not really very well unless you're Medicare. So Medicare has saved some money in this because as the MSSP programs have tried to implement things, Medicare has saved some money, but they're only willing to share that shared savings with the providers if they reach a certain threshold of savings. And then from that point on, they're willing to share with the provider 50-50. So in the first year, it was fairly dismal. Only about 22% of Medicare shared savings programs actually create a savings for themselves. And then once you throw in the cost of what it required to create that Medicare shared savings, then most of that savings is gone. Okay. Now, there are a lot of reasons for that. Again, the reasons of the way it's structured, reasons that the first year, typically when people are thinking about doing MSSP, a lot of times they'll wait until they get accepted to even start doing something, okay? So for those that start earlier and have been piloting and have been trying things, then they are the ones that tend to do better that first year. If you wait to get accepted and then think, okay, so Monday morning, I've got to start doing something different, then you're way behind and you're not going to make a shared savings that first year. Some other interesting things to understand about MSSP and shared savings, it is not related to quality, okay? So ACOs give you 33 quality metrics that you have to report on. And what they have found is the outcomes of that quality is not related to how much shared savings you get. And to me, that's not terribly surprising because the particular metrics that they chose to report on are typically a little bit more longer-term quality outcomes. And so you will create some shared savings if you're, or some cost savings if you're managing diabetes a little better and your hemoglobin A1Cs come down, and that is the right thing to do for long term. But in that first year, the things that really create shared savings are really on the specialty side. They're the transitions in care, they're the subacute costs, they're the LTAC costs, there's the bundling process within the hospital, they're decreasing length of stay. Those are the things that generate actual dollar shared savings. And in the first year, luckily, they only require you to report quality. They don't actually hold you accountable for meeting any quality standards. This slide was to me, kind of a duh. Okay, so if you think about spending across the country, there are parts of the United States where an average Medicare beneficiary, we spend in taking care of that person around $18,000 to $19,000 per year. Okay, so you can imagine that if you start out spending $18,000 or $19,000 per year and your goal is to get it down to 12, you can create a lot of shared savings. in those markets where you're only spending 7 to begin with, it's a little harder to create a lot of shared savings, okay? So Greenville County, at least, is in the $9,000 per year per Medicare beneficiary. So probably a little more difficult for us to generate shared savings this coming year. Doesn't mean we can't. Still, there's a lot of opportunity there, but you know, this is a statistic that that Medicare talks about, and it's pretty consistent over the quintiles as you look at spend in a given area. So what benefits has Medicare seen out of it? What they have noticed is that as the MSSPs have been developed, that a number of them are focusing on preventive care, a number of them are focusing on developing evidence-based clinical protocols, and 21% are managing chronic diseases. And if you ask the MSSPs, you know, where are you in the continuum of developing these processes, particularly around population health, about 24% of them said they're mature, 15% said they're non-existent, okay? And again, it depends on how long they've been at this and if they've been piloting or not. And in terms of size, this is kind of interesting. There's really no advantage in the financial performance of an ACO. So ACOs less than 8,000 patients did have a little bit higher average savings than those that were bigger, but not a lot. MD-owned ACOs do better. And that's going to be one of the points that I'm going to push over and over during the course of this discussion this morning, is that this will not work whether it's MSSP or a clinically integrated network if it is hospital-driven or if it is insurance company-driven. This has to be physician-driven, and the structure and the decision-making has to be in the hands of the physicians or it will not work. And then the other is that ACOs greater than 12,000 have a slightly better performance, quality performance related to benchmark, and that may be related to scalability of implementation. So, so again, MSSP probably not the best model, but it does provide some advantages that we're going to talk about, and I would recommend that despite all those poor statistics, MSSP is the place to start for most networks, and we're going to talk for a few minutes about why that is. And so most organizations, they hear all that, or they'll hear about a clinically integrated network that decided to try to be an insurance company and failed, and they're nervous about getting into this field. And so they take either I'm going to wait and see, or I'm going to be an early adopter, or I'm going to hedge my bets. And so I'm going to tell you a little story here about why you should think very carefully about waiting and seeing. So as you look at this chart, on the left-hand side, we're talking about organizations that have early pilots kind of playing around in the population health area. Then on the right side, completing the transition to a new model, which includes new population health model as well as a new payment model. Because if you just switch to a new payment model, you've just become an insurance company without the ability to change care. And so then that's the worst of all worlds, okay? If you change the care model and you don't change the payment structure, you're going to go bankrupt, okay? So how do you transition from piloting in those areas to a complete transition? And so for those of you in the room that are great stockbrokers, okay, you can time it just right and decide to make that switch and get across that chasm in a perfectly timed manner, then you'll probably do fairly well. Even with that, because of decreasing utilization and other things, you're probably going to come out a little less profitable. So the hospitals that get into this business realize they're going to have less butts and beds. They're going to have less ER visits. They're going to have less of certain things, and they have to figure out what their new model is going to look like. If you wait, so you do some pilots, and as you're going across that chasm, and you take too long to flip the model, okay, you're going to come out very poorly on the opposite side. If you do it too quickly, you're going to lose some money up front because you're making lots of investments, you're making lots of changes in population health before the model, the payment model actually changes. And so you're going to come out worse than a well-timed transition. But notice that you've come out better than a lagging transition. So the cost of moving too fast, so the difference between that yellow line and the green line is that circle. So there's a cost there. So we moved too fast, we spent a little too much money, and made a little bit too much investment before the model changed. The cost of moving too slow, on the other hand, although the cost is delayed, it is a much bigger cost to the system than moving too quickly. And that is a point to remember. And now I'm going to tell you a little story. So I was in Phoenix, I guess it's been 3 or 4 weeks ago now, meeting with a group of 10 other clinically integrated networks. And the purpose of the meeting, we're in a conference room around, very casual setting, just to discuss what's going on with each other, what's going on in our markets, what did we do wrong, what could we learn from each other, et cetera. So it's us, it's University of California, San Francisco, Ohio State University, Integrated Health of Wisconsin, Arizona Care Network. There were another handful around the table. The story that impacted me the most was, so Arizona Care Network's at the table, and this was their story. So in Phoenix, there's Banner Health, there's Dignity Health, if you're familiar with it, a huge Catholic health system across the country, probably one of the biggest healthcare delivery systems in the country. Ascension Health, which is another big Catholic system. Tenet Healthcare, for-profit system. Mayo Clinic Hospital there in Phoenix. So, and they're all doing well. So it's a vibrant economy doing really well. So Banner, a few years ago, decides to put together a clinically integrated network. The other hospitals are going, our margins are good. We're not getting into that business yet. We're gonna wait. If the market changes, we'll get into it. And then Banner signed an MSSP contract. And the other hospitals said, it's just attributed lives. It's not really a narrow network. It's just measuring quality on the patients they're already seeing anyway. There's a lot of cost up front, a lot of just painful stuff to have to do. We're not going to do that. So I think time went on, and about 3 years later, literally overnight, Banner goes out to the commercial market, goes to Intel, goes to the other big employers in Phoenix. Because over that 3-year period with MSSP, they had put their network structure together. They knew how to run the committees. They knew how to make decisions. They understood population health. They knew how to affect care and change care. So they went to those big employers, Intel, et cetera, and said, if you'll move all your employees to us, we'll cut your rates by 50%. 50, not 15, 50%. So guess what Intel did, okay? so not much loyalty there when you start getting more than a 10% differential. So the rest of the hospitals all of a sudden found themselves with no patients. I mean, their volumes dropped dramatically, every one of them. So they were scrambling, what are we going to do? And so you've got Dignity and Ascension Health, two big Catholic systems with a mission, and Tenet Healthcare merging in that market. And to hear some of the discussions described for two Catholic systems and a for-profit system sitting at the same table together, those you can imagine what those discussions look like, okay? So they formed Arizona Care Network and said, okay, we're going to compete with Banner. So they went around to the employers and said, we have a network now. And the employer said, okay, can you give me a 60% cut in rates? And they said, well, no, we can give you a 5%. And I said, yeah. So Arizona Care Network went back and talked to the docs and said, we want you to join our network. And the docs said, I can only belong to one network. Banner has all the contracts. They have all the population health expertise. They have all the analytics. Why would I join your network? So that network and all those hospitals are struggling. And it just so happened that our chairman of medicine was in California at a medicine meeting and came back and said, I'd heard your story about Banner. And while I was out there, I just happened to sit beside the chairman of medicine at the University of Arizona School of Medicine. And he told me the same story. And he said, and by the way, we just yesterday signed an MOU with Banner Health to move our residency to Banner Health because we didn't have enough students to teach our residents. Okay? So you can wait and see all you want, but I'd be careful about those decisions. And so they have partnered with United Healthcare. They have partnered with Aetna and with other insurance companies in that market to develop real products based around population health, and Banner is in the literature in terms of how well they have managed their populations. And so, again, MSSP can be that vehicle because it can be a no downside risk. You've got to invest, you've got to change your processes, but it's an upside risk only contract. And so it's something I would think about doing as an ability to play in that arena, learn how to manage care. Your organization's got to be willing to lose some money because you're going to transition a little too early and you're going to lose some money up front, but you have to do it. So given that, I'm going to talk about just some things that are required to make a clinically integrated network successful. First of all, it's got to be the organizational structure. So from an FTC standpoint, you have to have a board. If you have a board, then you can have employed, non-employed docs and hospitals working together. You have to be able to define your scope of care. What kind of populations are you going to manage? Your membership, and by membership, so what participants, what doctors, what specialties are you going to allow in your network? And you have to have a strategy to that for the FTC to approve you, okay? And you have to have performance requirements. So whether it's and that's one of the things, another thing about MSSP is it gives you 33 metrics to start out with that they hold you accountable for. So you start out with a list of metrics. And you have to be able to report them accurately, act on them, improve them, and you have to be able to hold the doctors accountable. So when it comes back to the membership, you have to be able to prove to the FTC that you have a remedial action plan in place. And if Dr. Egan is not performing well in his diabetes care, that there's a remedial action plan that helps, if it's a good remedial action plan, it helps his performance, helps his office understand what they need to be doing better to get those results up. And if he elects that he really doesn't want to participate in that, that you're willing to kick him out of the network. Okay? And so looking for Jim Ellis's head back there somewhere, but there he is. So I always like what Jim Ellis says. Jim Ellis is one of our ER docs who also organizes all the medical care for the Super Bowl and other sports events. And his analogy is, so this ain't rec league soccer, okay? Everybody doesn't get a trophy, and everybody doesn't get to play, okay? So, and we just have to realize that more and more we're going to be held accountable for our outcomes. And so having those metrics, the ability to collect that accurately to help doctors improve, make sure that what they're collecting for those outcomes are accurate, because I can promise you what's out there now that Medicare and other people are looking at, that the manufacturers of the world are looking at, is not reflective of what you're doing, because they get pieces of data. But if you do all that, then the FTC lets you function as though you are a single organization and sign a single signature contract for care. So with an insurance company, with an employer, whatever. But you've got to have all those pieces in place. The only other thing I'll add about this slide is that as we do that, so there's two things. Typically, most of the quality parameters and the shared savings around those, the pay performance things, typically are oriented toward primary care docs, which is important, and we have to do that. And they're typically the ones that are responsible for a large part of those 33 ACO metrics, for example. but you will never create the level you really need to be competing at, and you'll never create the shared savings without engaging the specialist. And what a lot of organizations are doing, in addition to an MSSP approach, is that within that, they are embedding bundles, whether they're real bundles that you're actually contracting for either through a Medicare bundled payment program or a commercial program. Sometimes it's just a virtual bundle within the MSSP program that just helps you be more efficient and get better outcomes around specific diseases. And so you have to be able to engage primary care doctors and specialists. This is just an example of the My Health First network structure. So we have a board of managers that's 12 members. We have the CEO from Self Regional Hospital in Greenwood. We have the COO from Greenville Health System. And we have one community member who's on Medicare. The remaining 9 out of the 12-member board are all physicians. And we have to have at least 50% of those 9 being primary care physicians. Okay? And they are responsible for every decision that's made. So if they don't approve it, it doesn't happen, okay? So it's very physician-led. I'm gonna flip to the bottom, and so at the bottom, those are the market areas of My Health First Network. And in every market area, there's a steering committee that's structured almost similarly. It's typically a couple of hospital folks, and the rest are docs, and the majority of them have to be primary care docs. And they discuss issues at their local area, either things that have been handed down from above that say this is something we have to do. They have to figure out locally how we're going to do that. And if there's issues, they push that issue back up. Okay? So it's an iterative process back and forth. But every area has its own local governance and input. That middle area for those committees, what we've asked is that every local market area have at least one doc sit on those other 4 committees. And so every area is represented. They get input into every decision that's made. And that physician goes back to that steering committee with that information and says, I was there when we made the decision, and this is why we made it. Okay? So there's that process back and forth. And by the way, there's now almost 1,900 providers in that network. So it's a lot of communication back and forth. These are the counties that we have a presence in. And having a significant geographic footprint is important. Because if you create a clinically integrated network and it's within the city limits of Greenville, not many employers you're going to be able to provide care for. Okay? So you have to have a footprint that's big enough to sign a big Medicaid contract, or to manage enough Medicare patients, or to have a contract with a big manufacturer who may have sites all over the upstate or all over the state. And they're going to want a single product. They don't want to go to a vendor. They're not used to going to a vendor and saying, well, you know, we'll have to pull 6 or 7 different vendors together to get you what you want. No, they want a single contract with single standards, single this, you know, everything the same. And so geographic footprint is very important. So important that a lot of the employers come to us and say, we like this, but we want it statewide. Because we have manufacturing sites in the Low Country, in the Midlands, in the PD area. We want the same metrics. We want the same everything for all of our employees across the state. And so we do have partners in these other areas that we're talking to, and eventually we'll wind up with a statewide network. And so doing all this isn't something, again, this is why MSSPs don't do well the first year. It isn't something that you make a decision in a corporate boardroom or in a physician group meeting and say, okay, so Monday we're going to become a population health group, and we're going to start taking risk, okay? It happens, and what happens a lot of times is that people will get together with their attorneys, and they'll form the legal structure. I'm now a network, you know? And I have a separate LLC, and I have a name and a logo, okay? If you don't develop competencies at every one of these blocks in this pyramid at a very high level, you will ultimately fail. And that's not to say that there's not some low-hanging fruit out there that's easy for people to get early on, but that goes away pretty quickly. And then you've really got to push that next bar in terms of managing those patients better and better. And so organizational structure, physician leadership is critical. And I don't mean a physician leader. I mean embedded physician leadership across the network. The docs have to own the network. It is their network, and those local steering committees, by God, they're going to make sure things happen. If that's not embedded and that culture's not there, you're not going to get anywhere. Care management, care model design, information technology around that reporting, the delivery network, the specialty ratios, and the ability from a finance standpoint to actually finance what you're doing ultimately and pay for all of this infrastructure. And this isn't little and it's not cheap infrastructure. And there are very few people out there that have the expertise to do things like this at scale. There are a lot of people out there who've done this in a pilot here or a pilot there, but to find somebody who's done it for 10 million patients, who's done it for Kaiser, who's done it for, that's a very different level of expertise. And those people are hard to find. And then figuring out what your common care model is going to be. And I realize that all this is complicated, but if you miss any of these pieces, you're ultimately going to fail. It's like building a car and forgetting to put one of the gears in the transmission. It just isn't going to work. And so having a care management model that looks at patient data, provider data, payer data, analyzes that, does risk stratification, predictive modeling, develops clinical guidelines that the doctors can agree on and vote on, and then integrating that across a common care model that incorporates every one of those things in those boxes down below. And then we talk a lot about the docs, and that is the engine that makes it run, but it's not just the docs. You have to go out and decide who is my best provider of DME services, who's going to give it to me at the lowest cost, who's going to be the most service-oriented, who's the best home health provider, what standards are we going to hold them accountable to, what nursing homes am I going to partner with, and what quality parameters am I going to hold them accountable to, what's the readmission rate from a nursing home that I'm willing to accept, what infrastructure do they have in place to actually make that happen. All those decisions have to be made, contracts written, those relationships built, and those transition and care processes from a population health standpoint to make that work. It can't just be a nursing home off to the side somewhere and you're checking in with them every once in a while. They have to be integrated into the delivery system on a day-to-day, hour-to-hour basis. And then having all of that infrastructure and the ability to do the data analytics, develop the care model designs, the clinical guidelines, et cetera. And we took the model from Kaiser when we were thinking about the Care Coordination Institute. So Kaiser, in my opinion, does this better than any place in the world. Otherwise, the NHS wouldn't have been in San Francisco trying to figure out how they do it. Kaiser manages about 10 million patients now. And what they realized as they scaled up is that they were having to, number one, recreate expertise in every market area, which is expensive. And they couldn't recruit the level of expertise they needed to recruit because they were having to do it 10 times. And so they stopped that and they pulled all the expertise out and they put it into an entity they called the Kaiser Care Management Institute. And those people wake up every day with nothing else on their mind but how am I going to improve the care model today? So they look at care model design, they do predictive analytics, they do their reporting, they develop the clinical guidelines with input from Stanford and UCLA and other places across the country. They have expert panels that give input into them. They do everything imaginable that you can think. They just got the contract last year to do the same thing for all the armed forces healthcare system. And they're visited by other people constantly. So we decided that, that made sense, and so we want to recreate that on the East Coast. And so that was the impetus for the Care Coordination Institute. Let's look at Kaiser's model, why recreate the wheel? Let's see what they have. Brent and I agreed that was a good vision. We brought the Quinn piece into it for some analytics and research and the care model stuff that Brent and Rob and those have developed over time, and now we're adding to it. We've brought people in that have had Kaiser experience. We brought others in, and we're continuing to develop that and fill out that CCI to have that. And you have to have that from somewhere, okay? You're either going to have to build that internally, or you're going to have to contract with an insurance company, or you're going to have to contract with some vendor out there to get it. And you can try to build it internally, but it'll take you years and multiple seven-figure numbers. And so, but it's critical, and you have to make a commitment to have those kind of services, even if you get it from an Optum or United or somebody like that. These are just big buckets of the things you got to think about. Health informatics, data analytics, data acquisition, scorecards, benchmarkings, tools, software development, care coordination. You have to develop a single care model for your entire clinically integrated network. It can't be one thing one place and a different thing somewhere else. It has to be a single care model design. Toolkits and resources, care management workflow tools, PCMH support, patient engagement, experience, education and training. Data-driven change management, predictive analytics, best practice. You can see all the boxes there. So it's a lot. Again, it's not something that on Friday afternoon you leave the office and say, okay, so Monday we're going to be a population health organization. Report cards. Everybody has to get standardized report cards. So again, all 1,900 providers getting the same report card with the same metrics that we've agreed on. So I think we report on 68 or 70 measures now. MSSP requires 33 or so. But we've all agreed across that network, these are the ones that we're going to measure ourselves on. We're going to hold ourselves accountable to these. This is the definition of them. This is how we collect them. This is what happens if you don't meet them, okay? And processes in place to manage all that. And so thus we become a learning organization. So everything we do, we learn from it. Hopefully it results in papers. Sometimes it doesn't. It's just rapid cycle process improvement, but there's a constant ability to look at what you're doing and continue to improve, and you need an entity within your organization that is constantly doing that. This is my biggest nightmare. As the president of the network, what wakes me up every night is communication, okay? So, and another story, so we're pulling together people within this network, and I've been meeting with certain individuals in one of the market areas, and then, we're trying to build this thing and put it together, and I get a phone call from somebody that's about 45 minutes away, and they said, well, we were worried about you. We haven't heard from you in a while. And I thought, it was just last week, okay? So, the expectations there of, all of a sudden, they want that constant communication. And one of the biggest reasons for failure I've seen is the setting of incorrect expectations and lack of communication. If you communicate with the docs and you communicate with the providers and they know what to expect, they're fine. It's when they build up stories in their head and they have certain expectations about what's supposed to happen and that doesn't happen, they get disgruntled. And so, unfortunately, for my poor new car, I'm on the road almost daily, going somewhere, meeting with somebody, having a meeting or a town hall or something, communicating about the network. And again, if you don't do that, it will ultimately fail, because it is now to the point for these practices, their incomes in future are dependent on it. So it's a big deal for them. And figuring out, if anybody can help me, this is one area that I really struggle with, is how do you communicate over an 11-county network with 1,900, 2,000 providers in it in an effective manner. That's going to be the next jump of how do we do that. Because they don't, let me tell you, they don't open emails. We probably have one of the highest email open rates around, and it's only 30%. So it has to be a face-to-face interaction. We send out newsletters, we send out emails, et cetera. That is not an effective way to communicate. So So all of those things I just talked about, and I know it's a long laundry list of things, but it's just the reality that if you don't have all those in place or working towards getting all those in place, and it sounds daunting, and it is, but remember going back to that first set of slides, this is where the expectations from employers and CMS is coming, is that you're going to perform in a alternative payment model, and the only way you're going to be successful in an alternative payment model is to do that. Okay? And so if you have all those things in place, you have a great network. So why do great networks fail? The first thing, and this has been shown over and over and over, is that if it is not truly physician-led, it's not going to work. So even as you look at the data on the MSSP programs, the ones that have thrived have been the ones that have been pure physician networks, because they make tough decisions. And sometimes when hospitals, and I'm a system guy, I'm born, bred, grew up as a hospital system guy, but hospitals are reluctant to make decisions that decrease their butts and beds. And I understand, because there's this transition phase that they have to get comfortable with. And luckily in our system, they've made that commitment. They've made the commitment that we understand what it's going to look like in the future, and we're willing to make the investments. And internally, we need to cut costs. We're trying this year to cut $100 million out of our infrastructure, because the system knows it has to be there to accommodate what's about to happen. But the physicians have to drive that and have to push that, and it has to be truly physician-led. The next is that the network doesn't get appropriate contracts. And so you can't live forever on Medicare contracts. You can't live forever on Medicaid contracts. You have to be out there getting commercial contracts, direct-to-employer contracts, working with insurance companies that, by the way, are also having to change their model. And this is very scary for them. And they're going to have to change the way they think about things and how they partner with providers too. But you have to have those type of commercial contracts. And it can't rely on just shared savings. So the promise to the docs out there is that, so we're going to go into an upside shared savings contract only, and if we get shared savings, we'll come up with this funds flow thing that says that you get some of the shared savings. The networks can never survive on that. The doctors can't survive on that, because you can't guarantee shared savings, and it's so variable from year to year. So the contracts really need up front to have PMPMs for care management. They have to have PMPMs for the network management that the network's doing. It has to have pay for performance things up front that pay doctors for doing the right things regardless of whether it results in shared savings or not. And your shared savings efforts are unfortunately a little different than just the pure quality things. They are two different things. Figuring out a lean process for managing patients through a subacute stay they're linked, but they're a little different than maybe a pure quality initiative around hemoglobin A1C management. Okay? Ultimately, those will result in shared savings, I believe that. But early on, you have to do both. And so those three things are why networks fail. Good networks fail. If you don't do those previous things, you're not going to have a chance of surviving anyway. But even when you put all that together, you got to make sure that you're approaching it from a business standpoint in a very business logical manner. And so that was pretty much what I had to say today, and I'm open to questions and hope you got something out of it.